Thank you, everyone. It's an honor to be a part of this session today. There are my slides, so hopefully everyone can see those. Hello, my name is Michele Battle Fisher. I go by she, her pronouns. I am affiliated with the Equitas Health Institute. So I am in the Midwest of the United States. That's where I'm calling from. So it's not the dead of morning for me. I'm right nice and spry for you today. We are a FQHC lookalike serving the LGBTQIA+ and BIPOC communities. And when I use the term BIPOC, I mean Black, Indigenous, and people of color communities, for those who are underserved, primarily with dentistry, primary care, and HIV services. So the title of my presentation today is Lessons in the Reduction of Health Disparities in COVID-19 by the Application of Critical Systems Thinking. And I failed to mention that I am a postgraduate researcher at the University of Hull, so it wouldn't be a surprise that I'm talking about critical systems thinking today. I do not have any financial disclosures to report. This is everything comes from me. So again, I'm talking about the US context, so I just want to make sure that's clear in the beginning. The Black, Indigenous, and people of color, BIPOC communities in the United States are disproportionately affected by COVID-19. And health inequalities in these populations just didn't pop up with COVID-19. So that's a point I like to stress. Actually, COVID-19 has exacerbated the problem of inequality in the United States. This pandemic has exposed a public health crisis within a crisis of worsened health outcomes among those who are BIPOC. Epistemic humility is at play because our understanding of COVID-19 is incomplete and is also socially and individually interpreted. So one understanding of the pandemic is provisional. It's incomplete, and we know that it's going to change from this point on. The question is, how is that going to change, and what effect will that have on health disparities? The social vulnerability of BIPOC during COVID is not adequately understood with the sole reliance on statistical methods or traditional paradigms. And I come from the public health world, so I'm going to speak from an epidemiological point of view, though I'm not an epidemiologist. But in public health, we use rates, we use modeling, we use traditional statistical methods, and we also use prevalence and incidence. And I said that's only one part of the picture. What we need to talk about is the lived experience of those who are BIPOC living under COVID-19. The use of hard system science, and I will preface this to say that I am affiliated with the Berthelotti Center for the Study of System Science. So I will say that first. So I am a disciple of hard system science. However, hard system science cannot answer every question. Likewise, science is not immune from making misjudgments, particularly when we're under extreme duress, which is certainly the case with COVID-19. But we have to remember that systems thinking, and I'm talking about systems thinking here, is not immune from this possibility of blind missteps with unintended consequences. So critical systems thinking, or CST, as I will use for the remainder of the presentation, is a divergence away from normalizing certain methodologies used one at a time, which is not adequate in terms of encapsulating or figuring out the full complexity of global crises rather than using traditional paradigms. So just to get a common vocabulary, I wanted to talk a little public health, if you don't mind. Health disparities. We have the designation of health disparities. When we talk about health disparities, we know that there's some type of statistical difference between populations. However, in order to be considered a health disparity, that doesn't apply to all significant health differences. According to Braveman, on a more granular level, health disparities must show a difference in which disadvantaged social groups persistently experience social disadvantage. and certainly BIPOC communities would be included in that category. So health inequality is a socially created complex system. We could say system within systems within systems. Health inequalities depend on interdependent social and physical systems that create and perpetuate those inequalities, which in turn lead to health disparities. So we have this persistent cycle of health disparities, which at this point we're trying to figure out how to get off of that ramp, but COVID-19 has only exacerbated the fact that we need to be dealing with this issue of inequality, marginalization, and oppression. So, social determinants of health and disparities. Social determinants are factors that play a role in health disparities. And I like to make this comment, saying racism as a health disparity, as a social determinant is not enough. There are elements to racism and oppression that need to be broken down. So racism and oppression and disparity, racism and oppression encompasses all of these health disparities. So the Kellogg Family Foundation supplied this graphic today. Health disparities are driven by social and economic inequalities. As you can see, they include economic stability, neighborhood and physical systems, environment, education, food, community safety, and social context, as well as the healthcare system. So let's just take a moment. And what we tend to concentrate is on the healthcare system, which is way to the right and is one of only 6 of these pillars. Now, I know that you're going to say that this doesn't look like a system as far as all of the nooks and crannies, but we'll get to that in a moment. All of these social determinants bleed into what we know or what we all understand to be health and well-being, those being mortality, morbidity, life expectancy, healthcare expenditures, health status, and functional limitations. BIPOC, Black, Indigenous, and people of color have historically experienced underlying comorbidities and risk factors that under pervasive racism and discrimination, which exacerbate the gravity and immensity of those health disparities. So let's talk a moment, we'll actually get into COVID-19 a little bit in just a moment. This is a pandemic of disease, but it's also a pandemic of inequality. So the pandemic of rampant disease such as COVID-19 is kind of embedded in a pandemic of inequality based on isms. It could be racism, sexisms, ableisms. The list goes on. Well, that's phobias. I can add that as well, but several different isms. So the pandemic of health disparity among BIPOC in particular, as I said, is embedded in an epidemic of socially created disadvantage that has no social or limitations or moral boundaries. It must be admitted that systems are socially created and is socially created by imperfect people who at this point do not see anything wrong with the system. But for BIPOC individuals, being a part of this particular system has grave consequences for their health. So let's talk a few statistics. The disparate COVID-19 mortality and morbidity among BIPOC individuals in the United States, and I'll say this is in the United States. Out of nearly 20% of US counties, and those are small sections of each state, US counties that are disproportionately Black, 52% of COVID-19 diagnoses and 58% of COVID deaths nationally within those 20% of counties occurred in those 20%. This is unacceptable, but it is the reality. Unfortunately, in the United States, for BIPOCs, living under COVID-19. Not to demonize epidemiology, we need epidemiology, so let's talk about that for just a moment. The rate ratios is another way of talking about risk ratios. If you notice, for Black and African American non-Hispanic individuals, a risk ratio of 1 is equal risk. What you want to see is a risk ratio lower than 1. But if you look at African Americans or Black individuals, the cases, sorry, that's my dog. The cases for African Americans are above 1.0. Hospitalizations is 2.8 the risk of majority culture, majority populations, and in terms of death, 2.0 the risk ratio. For Native Americans, Indigenous, 1.7 the risk ratio, 3.5, this is unacceptable, the risk ratio, and deaths among Indigenous populations, 2.4. Asian Americans, and according to, this is recent, but Centers of Disease Control, as of September 21st, 2021 rather, Asians are not disproportionately affected by COVID-19. That is not to say that it is not a problem, but according to the statistics at this point, there are other BIPOC communities that appear to be more grossly affected by COVID-19. So let's talk a little bit about critical systems thinking. Critical systems thinking, or CST, and I'll use CST, was originally conceptualized by Flood and Michael Jackson in a response to the heightened complexity of oppression within global crises that traditional paradigms and methods on their own lack in effect to persistent problem situations. And problem situations is analogous to the term systems, and we can get into the discussion of what is a system, but I'm going to use the term resistant problem situations. So according to CST, more is better. What I mean is more is better is more appropriate methodologies is better than employing only one method or paradigm that myopically looks at a healthcare issue. And we have to reflectively be critiquing those methods before we're using them. That is a tall order when we're dealing with global crises, to say the least. However, we have lived with COVID for 2 years. There needs to be a point that we are going beyond the modeling, going beyond the epidemiological data to actually start to reflectively critique the kinds of methods and paradigms that we are using. According to Jackson in 2018, there's a possibility that the elements and disparities during COVID-19 may be, quote, distorted in the quest for quantification. So it's talking about this social construction cannot be captured within data points. And I think that that is important. We tend to aggregate the BIPOC experience. Yes, we are aggregating in terms of the risk ratios. What we're not doing is drilling into the lived experiences of BIPOC individuals. Why are they becoming infected at higher rates? Why are they dying at higher rates? Why are they being hospitalized at higher rates in comparison to the majority population? So a significant requirement for appropriateness of a method is reflective critique. And a part of that reflective critique is to do a hard, long look at a method before we apply that method. I know a lot of us, we have our methods. I tend to think in social network analysis, a little bit of system dynamics. I admit it, but some of us may be big data, other of us may be data science. But we need to be thinking about the appropriateness of each method before we use it. Now, that doesn't mean that each one is not important and is not applicable, but I think the power of CST is that we should be called to be using different paradigms and methods in tandem. So we employ sets in science, we use things in tandem all the time. However, when we tend to do hard systems, it tends to be we're doing system dynamics, we're doing social network analysis, we're doing agent-based modeling, or from the public health perspective, we're doing epidemiological investigation. This leads to the point of a conceptual framework of the systems thinking that is better demonstrated by what we call the third wave of systems thinking, which is CST. So the components of CST are the following. Number one, critical awareness. Critical awareness it requires reflective critique of the methods before we employ them. So this reactance that we tend to do, we tend to jump into a method and we're like, oh goodness, we should have done something else. We need to take that time into doing reflective critique before they are employed. A part of CST, which is important, is the utilization of multiple paradigms, which can uncover joint disparities. According to Jackson, can uncover joint disparities, which he says are beneficial in utilizing multiple axes of social inequality. And number two, under critical awareness, we want to understand what the method actually does. And we also want to know what the method can do and what the method really can't do. What questions are answered by a particular method, and if a question is not answered appropriately or fully, find another method that can complement that. So understanding a method's applicability to emancipatory problem situations or systems, if you'd like to define it in that way, before using them. This is a major component of CST, methodological pluralism. No approach guarantees success due to the complexity and multidimensionality of resistant, wicked problems. What we want to keep in mind is when we are employing systems thinking is that we definitely can never guarantee success. However, we can increase our ability to have success if we are employing more than one approach which complements each other. Gregory defines discordant pluralism as sometimes we have these seemingly disparate analytical approaches that don't seem to fit, but we need to look at them as being complementary rather than competing against each other. So again, I further stress that the use of more than one method should be chosen after reflective critique, and that we shouldn't shy away from putting different approaches together because they appear to be disparate from each other. To reiterate and to restate is not to say that every paradigm or method fits health disparities in global pandemics. Rather, we want to find a proper fit of a method before engaging different methods along the way. That is fundamental. Functionalist approaches to health lend to functionalist requirements of causal relationships, replicability, and quest for regularity. Thus, critical systems thinking, or CST, guides us to use systems methods appropriately. And number three, improvement or emancipation. The most disadvantaged stakeholders are individuals that are affected by COVID-19, and which in this case will be BIPOC, must be taken into account and involved in the ratifying of the problem situation, meaning we need to stop measuring the life experiences or the health disparities of BIPOC individuals without having the active reflection of that community. It's not unusual for us as researchers to swoop into a community that's deemed to be disadvantaged, it's deemed to be oppressed, do our analysis, not leave the data, not explain to that community what we have found, and then we place it into academic journals. What I'm saying is what we need to do if we're going to be trusted as far as research, is that we need to have the reflection with the community, and we need to stop merely measuring about and in a community. So thank you very much. I have quite a few references if you're interested.
Thank you very much, Michele. It's very nice to see how all of our presentations come together to create this big picture of the system of the crisis. Can you unshare so that everyone can see the full screen again, Michele?
Okay, stop share. There you are.
Thank you.
You're welcome.
Okay, I open it for the floor.
Well, thank you, Michele. Sorry, I put my hand up again. Sorry. So that is an interesting methodological perspective on what we're doing, but it's very hard to get the whole picture. So
Right.
all of us are doing our bits, you know, our modeling or our interventions or our so could you give an example of how you've brought it together? Just one little example of how you brought it together in the CST model.
I must admit, as I mentioned before, I'm involved with pharmacology, so I'm general systems thinking theory is where I started, and there are moments where I'm still there, and there's nothing wrong with that. But the fact that I'm working in LGBTQI plus health and BIPOC health reminded me that there are individuals that are those data points, that are those little balls in our little nodes in our social network analysis, and that needs to not be forgotten. What was really apparent with critical systems thinking for me was the fact that it was looking more towards what we call Creswell's mixed method approaches, but with having more of a kind of like a theoretical basis to it, rather than having sequential or concurrent, actually having that reflective critique in order to choose what methods may be appropriate. That could be epidemiological plus soft systems methodology. That could be big data and critical systems heuristics. The combinations are endless. But I think with COVID-19, BIPOCs, as far as research, have pretty much been ignored as far as taking it back into the community and actually being used. Health disparity research is all over the place. Everyone does it. I think the problem is that critique of figuring out, so how is this emancipatory? How is this actually helping the community? Several of the speakers, you included, talked about public health and community health and how abysmal that the state of that is right now. And I do think that critical systems thinking has us take pause and say, so what can we do with systems thinking to assure that we are framing our questions in a way that hopefully encapsulates as much of the lived experience of BIPOC rather than the epidemiological, this person is a case, this person has a control in the case control study. I just love the fact that we're going beyond that.
Yes, it certainly fits nicely into the way of thinking in systems. And thinking in systems means that there's not one right way. There are many different ways to approach things, and the real issue is teasing out what is connected to what and what kind of dynamics arise out of them. In interconnections, what are the interdependencies within the system?
Yes, and CST is an overarching paradigm. So it's not to say that I'm not going to take social network analysis out of my back pocket and use it. It's not to say that epidemiology should not be used. It certainly should be used. We need these models. We need to know what the disparities are as far as data. However, we tend to stop with the data, which is quite unfortunate for BIPOC communities. I've lost individuals to COVID, just one recently. Out of my family, we've had 12 cases of COVID within my family, just my small family alone. So there is a gross disparity among African Americans. We tend to be front end workers, the individuals who are out in the community that do not have jobs, frontline workers rather, that have jobs that do not allow them to have leave, that do not allow them to not self-quarantine themselves. And so they're putting themselves at greater risk. They tend to live in domiciles that have many people, so that can increase the spread of the disease as well. So I just think it's really exciting to be here and to hear everyone's perspectives. And I will walk away with a lot of different information that hopefully I can take back to critical systems thinking, take back the hall, and hopefully be able to use, and I'm certain that I will.
Thank you, Michele. Anyone else with a comment?
I just got one comment. Sorry for talking too much, but one of the issues in the sort of multi-methods and it's something we've been struggling with for a long time, is actually the prominence of the hard data compared to the so-called soft data. And I think in the pandemic, at least in Australia, we've had a lot of journalists attempting to get the story of disadvantaged people and everything. And they have these stories, but it actually doesn't go anywhere. So the stories sort of, they may get published, but they're never published in the frontline journals. And so would you comment on that? How can we promote the lived experience in a way that will shape systems?
Yeah, I think that we definitely need to go back to the communities that we're measuring. We don't do that. Yes, qualitative has been the stepson or stepdaughter to quantification, and I will admit that. But with critical systems thinking, the hope is that if we're bringing those seemingly disparate methods together, that they're going to be making up for the lack that the quantitative might have, and maybe the lack of precision that you might have with, say, soft systems thinking or viable methods, something of that nature. So I have no answers. I wish that I did, other than to say, I think that Flood and Jackson are onto something, but I'm new to this, and every day I'm learning something new about critical systems thinking, but I'm still a hard systems person. I am.
Thank you.
You're welcome. Thank you so much for your question and your comment.